First of all, it's a nice place to be in, to escape from Kuala Lumpur. Unfortunately, it's been hit by haze. So after traveling and with the haze and all, I got a bit disorientated. So this morning, I went to town for a morning walk. And then I kept thinking, is this the market? Oh, it's a night market. Actually, I've been there at 8 a.m. in the morning. So no chance of actually buying anything for my wife, but at least I know I have an excuse for that. So the task given to me is actually quite difficult in a sense that trying to introduce to you some new concepts, and there were 4 things under the headings: characteristics of the disease, special circumstances, the needs, and also the support that the patient would require. So I can do it many ways, but I decided to cheat. So when it comes to characteristics, I'm just going to touch about the CLL itself, and also put some emphasis with the between the similarities and the differences with CML that most of you are familiar with. And then we're going to touch about why CLL is special, the challenges that comes with it, and obviously the last part, the support or the advocacy that I'm sure that you'll be interested in. So when we talk about CLL as treatment, we have come a long way in terms of treatments for CLL and also to all forms of cancer. One of the main success that we have over the years is from AML. So if you look at AML, if you look at 2 groups of diseases, we look back, 10 years? Okay, we started from the 1970s. They all look like if you were to be diagnosed with AML, you won't be able to live long. Come the 1990s, the 2000s, half of them actually survive. But the same cannot be applied to the older age group. And the main difference between these 2 groups is actually the treatment availability, and that treatment is actually stem cell transplant. So when we talk about stem cell transplant, that has actually revolutionized the treatment for all blood cancer. But unfortunately, when we talk about CLL presents at such a later age that transplant in this group of patients is not an option. So you have to be more clever. The treatment trend in Haemato-Oncology now, at the very beginning, we decided to transplant everyone. So everyone at the beginning of this stage of disease, you identify whether they are transplant candidate or not, you acquire the stem cell for treatment, and then you thaw them, and then you actually transplant the patient later on when the time is right. But unfortunately, not everyone can actually follow up to the journey. Some of them don't do well. We need a better agent to actually control the disease before we go through to the transplant. Which remind me about the pattern when we move forward. We know now that transplant, if we just stick to transplant alone, we would not be able to progress much. We have to be more clever. So if we look into all the cancers, there's a pattern to be seen. And we are very good at recognizing patterns. Last week, I went to watch a movie. Very nice one. It's called The Martian. It's a very good movie. It's about basically somebody that was actually stuck in foreign land, hopeless, and people go all the way to help him and all the way to save Matt Damon. Last year, I watched another movie. It's about somebody stranded in foreign land, and people actually try to do a lot of things to help him. And at the end of the day, they tried to save Matt Damon again. 15 years ago, we did the same thing. Somebody stranded in land far away. We went through all resources to actually save this fella. And again, it's Matt Damon. So spot the pattern here. Who's at fault? Is it the disease at fault? Or what's the common thing about this? So we make sure that we don't, the next movie that you see when Matt Damon is actually playing, I think you can already spot the plot. You know it's going to be stranded, and it's going to be safe in the end, and it's going to take a lot of resources. So we try to actually spot the common theme when it comes to treating cancer. So this is what the direction's been since the turn of the century. So from this, we developed this tendency to spot the pattern, and from there, the idea of targeted therapy came about. So when we talk about targeted therapy, the one that is actually of such a success was Gleevec. It revolutionized the treatment of CML specifically and the way we look at cancer. From this, we developed targeted therapy for other cancers. We developed targeted therapy for breast cancer, for even lung cancer, which unfortunately not as successful as imatinib has been for CML. But we're starting to understand the biology of the disease. While the target might not be the same, we try to do our best in finding other targets, and from there we look far and wide. And the next success that we talk about was actually in the field of treatment for myeloma, and we found thalidomide seems to be one of the better drugs. But we don't quite understand how thalidomide works. So we delve further into finding another target, and about the turn of the century, another kind of therapy came into the picture, the monoclonal antibodies. From here, we start to understand the way that the disease developed in cancer. Why are certain cells don't become cancerous while others do? And it's actually a lot to do with switching on and off of certain targets. And most of the genes that's been switched on, they are actually at signaling level. And signaling, I mean, is actually receptors. So receptors need something for it to actually latch onto and switch on and or off the process. So by using monoclonal antibody, you're actually feeding the switch with something that it needs. So hopefully by giving the right switch, you can actually turn off certain process and you can actually treat the cancer. It revolutionized the treatment for lymphoma with the introduction of rituximab. It revolutionized also the treatment of breast cancer by using Avastin. Then we start to go deeper. We not only satisfied with target being a receptor, we are not just satisfied with the target being monoclonal antibody host, we are now looking at the pathway itself. And this is where the interest in the field of hematological malignancy comes into the picture. And that's why in the last 10, 15 years, you see a lot of development in terms of Haemato-Oncology. So we live in interesting time. In myeloma, we have a drug called Velcade. Previously, people with myeloma, once you get the diagnosis, you basically got months to live. At the most, you got 18 months. With Velcade, it's an injection that you give like somebody's having needing insulin in diabetes. You actually extend their life. Now the median survival is 8 years. Median survival means that if you got a bus with 100 people, 50 of them will die after 8 years. So that's how good the treatment is. But it's not without side effects. There are other drugs. Brentuximab. Brentuximab is actually a treatment for Hodgkin's lymphoma. The response rate from Hodgkin's lymphoma in people that all other drugs doesn't work is about 80%. And that's not heard of before. Cost-wise, it's another story altogether. Closer to home, there's a new drug that actually developed for CLL. It actually blocks one of the pathway we call the BCL2 inhibitor. It's an older drug. It's actually akin to Gleevec. If you look at the name, you got ISIP at the end. Different target, but it's actually an inhibitor as well, an oral agent. And another one is a monoclonal antibody that actually has been proven to revolutionize again in people that has got refractory disease when it comes to CLL. So in the last 15 years, we moved so far. And if you look at the theme in the target, initially there was a lot of interest in AML, and then lymphoma came into the picture with the advent of rituximab, and then multiple myeloma, And nowadays, we attack everything with a target. So CML, CLL, we also got treatment for PNH, treatment for ITP, a lot of hematological malignancy or non-malignant disease can be treated by using specific target. We're also using the same treatment to treat rheumatoid arthritis. Why? Because in rheumatoid arthritis, there's actually a target to be attacked. There's a pathway that actually increases the inflammation of the joints. So by targeting that target, this patient actually get benefit, and they don't actually have malignancy. So we should not just close our mind in terms of all this kind of treatment, all these targeted therapies only for malignancy. They can be used for other things as well. Now, let's get back to CLL. So we ask ourselves, how do CLL present? I mean, we had a session about it earlier. Well, usually it's incidental finding. When you found a white cell, there's more than usual, so that's a nice white cell for you. But in the blood, it doesn't look as cuddly, okay? It looks more malignant. And the problem is, it interferes with the normal function of the other cell. If it just sits there alone without actually interfering with anything, we just leave it alone. It can do whatever it wants. But unfortunately, over time, it starts to interfere with production of red cells, production of platelets, and start to actually reduce the ability of the white cell to actually do its job. So you end up with infection. And the infection can be straightforward. It can have a bit of myeloma, a bit of pneumonia, but in some instances, they have skin infection, they actually have shingles, things they're not supposed to have. So you start to think to yourself, there's something else going on here. They can also use all the energy in production of red cells and white cell and the platelets, so they actually channel their energy at the wrong place. We're not talking about weight loss and fatigue while you're actually trying to get a six-pack like me, but we're talking about weight loss without effort. You just lose energy just like that. So there's a distinction to be made. And when the disease progresses, you start to see more worrying signs. You start to see lymph nodes appearing. It tends to be in the neck, but it can be in the groin, it can be anywhere else, and sometimes in an area that you can't see. So the patient might actually come in complaining of abdominal pain. The surgeon thought that the patient actually have appendix, went in, tried to do the operation. Yes, they did the operation, took out the normal appendix, closed it back again, said, well, the patient's normal. And then they do a white cell count the next day, and they found that the white cell count is high. They thought, oh, maybe there's an infection. But then again, it can present with funny ways. And as the disease advances, you start to see the spleen become bigger, the liver become bigger, and starting to mimic CML now. When we say mimicking, let's see the similarities between the two, CML and CLL. It's a chronic cause, so the patient tends to live for many years with the disease. But in CLL, the snapshot that we take sometimes can be a bit different. In CML, the chronic phase may take 5 years. So when you first were diagnosed with the disease, you can never tell whether you are actually diagnosed in the first year, the third year, or the fifth year. And maybe that's why some people progress a bit faster. Some people actually have more basophil in their blood because they are about to turn into accelerated phase. But the same measurement cannot be applied to CLL. CLL, the chronic phase, so to speak, the asymptomatic phase may last for about 10, 15 years. If they are actually in rise 0, they can actually just look like you and me. They don't have any symptoms. The only way that they find out is because they went to see the doctors, and the doctor actually did a blood test, and then they found out the white cell count is actually high, but the patient got no symptoms. So the symptoms non-specific. So there's nothing we can tell to the patient to say, watch for this, this, and that. It's just a blood test, unfortunately. Once they actually develop the lymph nodes and all, it might be to the phase that they need treatment already. The way that can be similar to CML as well, apart from the white cell, is the fact that they actually have a large spleen. So with CML, patient with large spleen, they can actually have, when they actually have some meal, they feel that, well, they get full very quickly. And the same thing applies to patient with CLL as well. There's no differences in terms of the size of of the spleen. They don't get more pain if you actually have CLL compared to CML. Although people say that if they were to have a sting, they were to actually get a sting from a bee or something like that, the itch that they get is actually more than usual. It's something to do with the excess white cell count carrying some material that makes them more allergic to things compared to CML. But that's not enough for you to say that it's diagnostic of something. So you need to take it one step further. They would need frequent tests, but nowadays we don't marrow everyone with CML. For CML to be diagnosed, it's enough to actually have a blood test. It's enough to actually have a test called flow cytometry, which is slightly different from BCR-ABL. Because with BCR-ABL, you use PCR method to look at the specific cell. But in flow cytometry, you want to look at the characteristic of the white cell, what kind of white cell they are. And from that, you can tell whether they're mainly myeloid or they're mainly lymphocyte. And also, you can also get some idea in terms of how aggressive the disease is going to be from the flow cytometry report. And once you get diagnosed, similar to CML as well, they need regular contact and regular advice from a medical healthcare worker. But it's not similar to CML in the sense that they would need treatment then. They just come and visit us every 3 to 6 months for a blood test and nothing else. Say hi to them, and then they were wondering why they're paying the exorbitant consultation fees to us. But it's actually doing nothing is actually good for them. It's part of the treatment. Watch and wait is a treatment form. Similar to CML again. The treatment that we have, apart from stem cell transplant, is just to control the disease. In CLL, you might not need anything to control the disease, so you just need frequent monitoring. Although in CML, the drug is actually given. The earlier you give the intervention, the better the patient get. But in CLL, you often don't need those treatment. The treatment also been evolving. If you were to invite me to talk again in 2 years' time, I may actually say different things in terms of treatment plan when it comes to CLL. Okay, in CML as well, it's not just giving imatinib nowadays. Already we are talking now to the level of when is it safe to stop imatinib. So the treatment is actually evolving over this. There's a lot of things that we still don't know about CML as applied to CLL as well. But there are certain differences, and the differences can be quite stark between these two diseases. The age of presentation is one of the main difference between the two. The youngest CLL patient that I diagnosed was a mother while she's pregnant. She's 36 years of age. That's the youngest that I have. I transplanted her at the age of 42 and she's still around. That was back in 2004. But that's an anomaly. Actually, when I first saw her, I couldn't believe that it was CLL. I was actually looking for other things. I was trying to convince myself whether it's CLL or CML. Oh, sorry, whether it's AML or ALL. I thought it was more acute leukemia. It's very rare. The majority of patients actually present at older age. And the main distinction as well, they don't need treatment. Okay, so as was pointed out before, the psychology for this patient is a bit different. The way that you talk to them is different. The way that you try to convince them to go on with their life may be different. The strategy is different altogether. The monitoring plan, because of that, is also not similar. It's completely different with completely different emphasis. And we actually talk more about infection prevention compared to CML. In CML, we talk more about what to do about your bruising when it comes, when you need to actually take your Gleevec certain time of day. How do you actually manage the side effect from taking Gleevec? But in CLL, we talk more about the effect of fatigue, more about the chance of getting infection, more about the need of immunization every year. The treatment target is also different. Different in the sense that we have a treatment target in CML, we haven't got much of a clue when it comes to CLL. So in terms of establishment of a specific target, we still lag behind in CLL compared to CML. The treatment patterns also tend to be different. It's tend to be short and sharp in CLL. So you got the disease, you need treatment now, we give you chemo, and then we stop. Come back to CML, you just go and have a chat, start them on oral treatment and go on for many years. As the treatment evolves, there are other agents in CLL that you can give and the patient actually take for many years, but this is not first line. This is actually third or fourth line. So you give chemotherapy first at the beginning, either oral or IV, and then that is enough to control the disease for about 4, 5, 10 more years. Then only all this other agent will come into the picture much, much later. Hence, the side effect profile is different, so the way you tackle them is different as well. So, as you can see, there's major difference between these two groups. Okay, I'm going to open this for question because I want you to understand the difference now before we move on.
Okay, who would like to throw the first question?
Sure.
A CML, CLL question.
If you can talk a little bit about immunotherapy in terms of, is it something that you go to the doctor, you're impatient when you get it? Is it a 1 day? Is it a shot? Is it like chemotherapy? What is the difference with chemotherapy?
The question concerns the modality of treatment called immunotherapy. Immunotherapy are all given in the form of intravenous. There's no oral form of immunotherapy as far as monoclonal antibody is concerned. So at the moment, it's given intravenous. And the other aspect of the treatment with monoclonal antibodies, it doesn't work in isolation. You need it in combination. Most of the time, at least with other steroids, or with mild chemotherapy. So the treatment, when you discuss with the patient, is actually a big step for the patient. From no treatment to something that potentially can harm them. It's not like a nice little transition like when taking from no treatment to a bit of hydroxyurea or imatinib. There's a stark difference between the two. So in terms of the commitment from the patient as well, it's actually a big life-changing decision for the patient. So the way it's given is usually inpatient, although the patient can actually get it as an outpatient if the patient can tolerate the first dose. Usually it's given intravenously, and because it's an antibody, the main side effect is actually similar to an allergic rejection. So you monitor the blood pressure, you monitor for any signs of itchiness, and also signs of like if you're being given something that you're allergic to. So it's as simple as that. It's quite safe to actually give. Okay.
Okay, I have a short question,
Sure.
Doctor. So up front, we bombard them with chemo, and then oral drug, and then for a while they remain okay. Is that similar to CML's stop treatment? Or treatment-free remission, that stage?
Yeah. So in CLL, when you give the chemotherapy and then you stop, the patient is not actually disease-free. You give the chemotherapy to control the disease. The white cell count might actually be still high, but you just wait for it for another few years before it double up again into the level it was before, and give the next kind of agent for treatment. So the patient is never disease-free, similar to CML. You give the therapy to actually control the disease. The disease is still there, but in terms of the lymph nodes, it may have disappeared, but the white cell counts still remain elevated in this group of patients. So it never actually gone completely normal. Hence, the reason why they have still increased risk of infection.
I was about to say that. When you say still okay, but above normal levels for the white cells, that means they're open for infection. So the more that we should monitor them.
Most of my patients, depending on what agent you use at the beginning, they may need still to actually take antiviral or antibiotics for about 2 years. So they need more frequent monitoring once they commit themselves for treatment. Before they actually have treatment, the monitoring is actually quite easygoing. But once you commit yourself for treatment, the treatment suddenly become more intense. So that's why it's a life-changing decision for the patient in CLL when they decide to have treatment. Okay, you're actually the drive for treatment and also the monitoring completely swing, because it's suddenly become a big deal. While initially you just watch and wait.
One question.
Sure.
Can I?
At the back first, YC.
I see.
Yeah. Oh,
I see
okay.
you.
I just have a question in terms of the cost of treatment. For CML, we know that it's just the price of a single drug, and besides the other. In this case, you mentioned that the treatment is in a very sharp and burst. So does it mean that the cost is just a one-time thing, and then after that it's just a matter of following up for the next few years?
Yeah. Yes and no, because it depends on the agent. Some of the agent that you can give is actually very, very reasonably priced. Okay, you give them short-term treatment for 6 rounds, then they go into remission. You just monitor them, so the cost is nowhere near Gleevec. But if that treatment fail and you need the monoclonal antibodies, you need the more hi-fi treatment, then the cost may escalate. And in fact, it's actually tend to be more expensive than Gleevec alone. But because it's given in short, sharp course, the impact of the cost is felt more to the patient there and then. While in treatment for CML, especially when they're getting it at no cost, the tendency to actually become non-compliant is a bit harder. While in CLL, got no choice, isn't it? You lose your hair and then you just go ahead and complete the treatment. So the impact is there and then. So that's why the support that you need to give is slightly different compared between these two groups.
Mashadek.
Yes. You mentioned about the rituximab for MAPTERA.
Yeah.
So when a person is suggested to have MAPTERA with chemotherapy, he or she cannot afford it sometimes since MAPTERA is quite expensive. So he or she has to finish his treatment with only chemotherapy. So how is the recurrence chance of this disease without MAPTERA or rituximab?
Yeah. So we are now dealing with the treatment-specific response. Okay, depends on the combination that you use. Obviously, internationally the first line of treatment is combination of 3 drugs, which is fludarabine, cyclophosphamide, and rituximab. Okay, the data comparing between just fludarabine and cyclophosphamide compared to fludarabine, cyclophosphamide, and rituximab shows that rituximab gives, in terms of response rate, it's almost the same, but the progression-free disease, not survival. There's no survival benefit for giving rituximab. But the time from the first therapy to her needing the next treatment is prolonged by a magnitude of about 18 months. So, if you don't offer rituximab frontline, it's not the end of the world for the patient. But we have to understand that we have to make arrangement maybe for her to have rituximab the next time the disease comes. Okay, it's not too late to give it then. Okay, the only difference is without rituximab, the chance of the disease coming back is higher at a shorter time. It's not that by giving rituximab, it will make major difference between the response between the two. Okay, you still need chemotherapy, and chemotherapy is the main thing. The immunotherapy in this setting is to actually keep the cell at bay. So the data between FC compared to FCR, the response rate is about the same, but the chance of the disease coming back earlier is higher without rituximab. So that's why we tend to actually offer rituximab in the hope that the next time when the disease comes back, it will be a lot longer in the future. Yeah.
Thank you. Can I extend the question again?
Sure.
So, if the disease doesn't come back in 3 or 4 years, what we should call the stage, remission or completely cured or partly cured?
Rise 0.
0.
Yeah. Depends on the classification.
Okay,
Yeah.
okay. Thank you,
Yeah.
thank you, doctor.
So we don't stage it as second chronic phase or anything like that. Again, we're just trying to highlight what's so special about CLL. It's actually the way it presents is not straightforward, and usually a patient may actually thought that he or she has some other disease, and when they come to the doctors and they were told that it's actually something else that they actually had. So the shock factor for this patient is actually a bit different compared to in CML, where they know they're not feeling right for some time. They might have a spleen, they might have fatigue, and then when the diagnosis was given in those asymptomatic, they're not as as shocking as in patient with CLL, where the majority is actually when they actually don't have any symptoms. Okay, the patient may also be feeling well throughout. So when you're sitting there with the patient trying to talk about the treatment option, they might resist you because they feel that they're doing okay. And it's just the white cell counts being up. It's not something physical. It's something that's on paper. They might have tendency to say, well, I've been living with this elevated white cell count for the last 5 years. Why is it special to actually have the treatment now? So that's another aspect of CLL that we actually sometimes need to look into. And in terms of predictability, if you think that CML is unpredictable because there's always a mutation that can happen at any time, spare your thought to CLL. In CLL, you can be well 1 minute, you have an infection that you thought is completely benign, and before you know it, you're septic already. Okay, so in terms of the cause of the disease, it can be rather unpredictable. So the white cell count can suddenly decide to go up, the spleen might suddenly grow, and before long, they might have to make a decision about needing treatment compared to when CML is more predictable. You can see from the pattern rising, the PCR is going up, for example. And then you can make plans about what to do next in terms of intervention. Should we switch to nilotinib? But in CLL, it's not as predictable as in CML. So the most important thing in CLL is actually the staging at the beginning. Which RI group does this patient actually belongs to? Because that will tell us a lot in terms of how they're going to do in the future. Okay. So the challenges, again, the older age group at presentation, and with older age comes the baggage that they carry with them, unfortunately. They tend to have more in terms of heart disease, they tend to have more in terms of problem with the kidneys or the liver. So their capacity to fight against infection, to actually tolerate the chemotherapy or the treatment that we plan for them, may be a bit less than somebody maybe in the CML, a typical CML patient. And with the treatment, because of the age factor as well, they may actually have already underlying diseases, say in the kidney and all. So you actually had to close off a few of their treatment options. So you're not able to actually give them treatment that you would have otherwise be able to give to other patients. And in Malaysia, at least, there's always a social issue. They're not independent, unfortunately, in my country. They're more independent when I was working in the UK. They take it upon themselves to travel 40, 60 miles to just get treatment, to see their doctors. Over here, over in Malaysia at least, if they live out of time, they have to make arrangement for the travel. Their children usually have to actually do that for them. And sometimes they feel that, they're giving burden to their children, and they felt that, well, it's probably not worth going through all this. Let's just keep it nice and tidy and not tell anyone. Unfortunately, those are the kind of challenges that we need to look into. And up to about 2-3 years back, there's hardly been any progress in CLL. And even today, mainly the treatment for CLL is actually extrapolated from the low-grade lymphoma treatment. So there's bendamustine, this GA101, this adalimumab. They actually stems from research in the low-grade lymphoma group. And we found out that it can be translated into CLL. So rituximab has only been available for the lymphoma patient in the last 15 years, only been licensed in the last 5 years for CLL. But in saying that, they actually do well. Okay. And now with the emergent targeted therapy, it's actually, again, although it's an it's what you call extrapolation, they're still getting the downstream benefit from the research from lymphoma. So the treatment plan, when we sit with them, is not as straightforward as in CML. In CML, you got option A, B, or C, or transplant. But in CLL, transplant is not an option. You can watch and wait, and as you can see from the slide earlier on from Dr. Wong, there are 5 or 6 of them, and they're not all, well, they're all relevant at a certain point in the journey, but it might not apply to them at the current time. In most patients with CLL, they have comorbidity, their age is actually a bit more advanced. So in this group of patients, the clinical trial has been done before, they would have been excluded from. So they are very selective in terms of using the drug for CLL patient for clinical trial. So in the patient that I see in my clinic or you will be in contact with, they might not be in the group that is suitable for clinical trial. So we're actually taking risk by giving these drugs to the patient because we don't have a foolproof data in terms of the safety and also in terms of whether the drug will give them benefit as what the clinical trial actually said. This is the worst part. If you go to, I did talks for the general practitioner in Malaysia, and I talked to them about, have you seen any CLL? Or worse still, I get referral from one of them, and I saw the patient white cell count is 100,000, and the patient was told by the GP that, well, you got leukemia. I don't know how to treat you, but I know somebody that can. So the patient sometimes travel from out of town, come and see me, and they were in tears because they thought that it's the end. But what they actually had to do is just monitoring. So the understanding in the community, not just at the level of a layperson, even amongst doctors, is still lacking. Because we assume that if the white cell count is high, it is leukemia, and worse still, they say wrong things to the patient. I have a patient before that unfortunately doesn't believe in the conventional treatment. So she ended up having steroids with one of the traditional practitioners and was actually admitted to the hospital with complication of steroid therapy. She came in with confusion because the sodium was very low, and she had problems swallowing because she had a lot of thrush down her throat. So it's a sad thing because of misinformation. While this patient actually would have still been doing well, she did okay in the end. And after treating her, I told her actually that she doesn't need any treatment at the moment. But she didn't come back for another 6 months. And when she came back later in 6 months, she said, oh, the actual traditional doctors may have treated her, so that's why she's feeling well now. So you can't win. Okay? So you can't win. So it's the chronicity of the disease actually gave us false reassurances. Not like in CML. In CML, we know that the longer they survive, the longer they tolerate Gleevec or nilotinib or the other TKIs, you know that they tend to be better and they feel stronger and they understand the biology of disease and the disease is more predictable. But in CLL, there's no such reassurances. Okay, you don't need treatment for about 5 years, and then you've been told that you need short, sharp treatment. You had chemotherapy for 6 months. And then after that, you went to RI1. You don't need treatment. So you've been left without treatment except for antibiotics because you had chemotherapy. 3-4 years down the line, you develop problem again, and you were given treatment, this time with more expensive treatment. So the patient after a while feel that, is it a death sentence that they had? That why didn't the doctor give me the treatment right at the beginning and make me feel well? So trying to convince the patient that this is the normal course for the disease can be a challenge for me. And as the disease progress, the treatment becomes more expensive. Unfortunately, that's what we have to deal with. So, for you to take home, I've been doing this for since 2006. That was picture is it 6 lah? I got proof. It's November. Oh yes, I still got white hair. I don't have white hair yet. So 9 years of advocacy did this to me. I've gone cuckoo. Now I've become a toot-toot driver already. So it's taking a toll on me. And, you know, the big C is something that, something that needs to be taken seriously. And when you talk to the patient, you need to have some sensitivity. And who is more sensitive than people that either have the disease or been looking after patient with the disease? You're going to do a lot better work than I will ever be able to do. Okay? So, you are the ones that are going to be defining the role, because you are going to be the voice for the patients. The patients, especially in CLL, they're in the elderly population. They don't want to burden their children. They tend just to sit quietly, and for them, they may have had a fulfilling life, and they felt that, well, they had enough. So they had a good innings, so to speak. So they felt that there's nothing left for them to achieve in life. So your job later on is actually to drive them, to support them, okay? To support them, to actually bring them forward, and for them to actually seek help. And the majority of the patient doesn't even know about the treatment options that is available. As far as they're concerned, if they got leukemia, they need treatment. And there are a lot of things happening now. And as Dr. Wong mentioned just now, there's a lot of clinical trial being put up. I was involved with one, the one that he highlighted, but I had 0 recruitment. Why? Because the other treatment works, and that treatment is actually for relapse refractory disease. So the patient had to fail other treatment or cannot tolerate, and the disease is back. So most of my patients, when they come in, they're still either in wait and watch, or they had some FCR, they're doing very well, or they don't want to come more often than they do now, every 3 to 6 months. If they enroll to clinical trial, they need to see me every week, and probably they had enough of me. And public forum. That's another thing that's very important for us to actually disseminate the information, actually help others in need. So, and with that, thank you very much. I'm willing to take questions. This is from my walk this morning.
Okay, we have room for one question from the audience and from the co-chairs.
Okay, sorry.
Yes, Dr.
One?
Razak.
Yes.
So we as an advocacy, we have quite used to advocate patients with CML. I think relatively because CML is relatively predictable, we can always tell them first line, second line, first generation, second generations, okay, and then the focus of our advocacy works, one of the component is compliance, okay, but in contrast to CLL is very difficult. So because the disease progression, the treatment is also so complex, also part of our knowledge is still very low. So what is your advice if, let's say, we are into advocating CLL patients or community? What are the focus of us, I mean, in helping them?
Yeah. I've been lucky enough to be involved with the actual group that I was involved with was in the UK. It's called CLL Support Association, CLLSA. I think the website for it is cllsupport.org that you can access, and they do a lot of public forums. And what they do is they don't educate the patients as much as the general practitioner or the doctors. But obviously the emphasis is different from region to region. They've been very successful in actually educating the general practitioner. So they actually go and talk to doctors and GPs actually, talking about treatment. In our setting, I think it's something that we need to sit down together and think, because to be honest, if you were to ask me up front, how can we support? I can only suggest that we do a public forum, because in terms of the catchment for the patient, they're not a group that are going to be committed, because they are not on any treatment, you see. So it's very difficult to catch on them and get them committed. So the role is more dissemination of information, the way I see it. It's a different challenge to CML group.
Mei Ching.
Dr. Haris, I have a question.
Sure.
How many, in your guess, how many CLL patients that you think, let's say in our country, compared to our CML group?
Okay. We have to look at it this way. There are two aspects of the epidemiology of CLL. One is the incidence, the other one is prevalence. Incidence meaning that you're being diagnosed now, while the prevalence is how much of them are still in the community. So in this group of patients, it's one of the disease that the prevalence very high, but the incidence may be low. Yeah, and if you look across in terms of prevalence, it's a lot of them. But because the incidence is low and the access to the clinic, or the need for them to interact with the healthcare worker is lower, so we might actually be underestimating the number all this while. There are a lot of them, but they don't need to be seen by anyone because they're not symptomatic. So we end up missing them out, and they progress on with the disease, and they were to die from diseases that are not recorded as CLL. So we would never know the actual number at least in Malaysia.
One last comment, Doctor, and maybe you could leave us with the answer to my comment. I think the CML community or the CML patients comparatively are luckier than the CLL patients in terms of laboratory testing equipment, in cases of first identifying the disease. That would be probably karyotyping and then even cytogenetics, and then monitoring the disease, FISH, and then now PCR. But PCR is okay, it's mostly available in our countries here. But what are the chances in third world countries, not only in Asia, when the patients could have been diagnosed with something else rather than the correct diagnosis of CLL because of the lack of those technology machines?
Actually, contrary to what's going on, CLL is actually not that difficult to actually diagnose, because it can be picked up on a simple blood test. Obviously, the confirmation later on would need something more specific, but most of the time you can diagnose it by just a peripheral blood film, and also exclusion of other condition. The blood film from CML and CLL is completely different. You can spot it straight away from the blood test. There's also the symptoms when you talk to the patient, but unfortunately we don't have something like BCR-ABL and things like that to actually. Usually you don't even need a bone marrow test to actually diagnose the CLL patient, but you would need this test when you think that the patient needs treatment, because when we talk about treatment, we need to know the cytogenetics of the patient. We also need to know whether the patient's transformed into a form of more aggressive leukemia. So from the bone marrow, you can only tell that from the bone marrow. But from the blood test, you can safely use that as a tool to diagnose somebody with CLL. And if you look at the classification of CLL, the staging, the right classification, it doesn't include a bone marrow test per se. It's more of a clinical kind of test that you need, but you need a blood test, obviously.
Okay, so again, I'm still into the context of trying to find the
Sure.
CLL patients out there for the advocate groups. So again, in the setting of a third world country, should we align ourselves with the GPs or the hematologist?
GP is the first stop.
GPs,
Yes,
okay.
definitely. That's what we've been trying to do in KL as well, and that's what the NHS have been doing. They try to highlight, because the cases are picked up in the community and they have a very good primary care setting. So over here, if we can educate our GPs in terms of when to pick up this condition before they develop infections or progress to RAI 2 or 3, it's better.